Hello, everybody. Welcome to our May 26th community call. I'm going to give a few more minutes because folks are just rolling in at the top of the hour. This is Sarah DeSilvi, the Director of Terminology for the Gravity Project. I'm probably going to start like just maybe 1 or 2 minutes just to allow folks to enter. Okay, so I think we're going to start. There's always a fair number of announcements at the beginning, and hopefully our friends will start rolling in. Again, welcome to the May 26th community call. It is the last public call of our spring 2022 build session. So it's a big one. There's a lot to do today, and we're just so grateful you're here. And we're going to get going. Next slide, please. I say this every time. Given that there are new folks, I'm going to say it again. We always mute individuals upon entry. Those who've been here in our meetings know we really work hard to integrate information from the chat into the call. So if you type it in the chat and send it to everybody, we'll make sure it becomes part of the conversation. Because the chat is a critical way for people to have their voices be heard, we do ask that any side conversations be pulled offline onto email exchanges so that we don't get too confused about the meeting at hand. Again, just please send chats to everybody so that we can all see them and they can become part of our conversation. Next slide, please. This is our common antitrust practices slide. We need to present this every single meeting. So any Gravity Project participants have the responsibility to comply fully with federal and state antitrust laws. Next slide, please. We are going to give a final hurrah for this session. Again, the spring work is kind of wrapping up and we go into summer internal time, but we want to make sure that anyone who's been joining our meeting is officially a member. You can join the Gravity Project officially at the link in the chat. You can check if you have already signed up or if someone from your organization has signed up in the second link that will drop down. And then the Confluence is an unending supply of information regarding the Gravity Project. It's important to sign up, especially as we go into our quiet times, because we will reach out and stay in touch with anything regarding Gravity deliverables. So we'll let you know when there are any policy updates or terminology updates in our regular email exchanges. We just won't be an active build. And so there's this public meeting reviewing build will quiet for the summer. So if you are signed up as a member, you'll be sure to get all of the key informations and updates until we meet again in August. Next slide, please. A very important nod to all of our old and new friends who have supported us, whether it's through in-kind support and labor, grants, our project founders, just so very grateful. You can see a pretty wide representation across our stakeholder groups. We're very, very grateful for all of your help and grateful for any old and new friends to support us in our work. Next slide, please. This is still true. So the Gravity Project, we are a collective. We come together from all of our different organizations to do this work. And we're funded exclusively through stakeholder sponsorship. As many of those who have attended the call know, we're currently in a funding gap that required kind of downsizing our activities in order to prioritize the remainder of a spring build. We really hope we address that funding gap sufficiently to pick up and keep on going in August full steam ahead, but we do need support to do that. So if you have any ideas about possible Gravity sponsorship opportunities, please send them to gravityproject@emiadvisors.net or visit the Gravity Confluence, and there's a specific page regarding Gravity Project sponsorship and how to become a sponsor. Thank you so much. Next slide, please. The agenda, we'll go through some announcements. We'll do overview our schedule, and then we'll talk about looking ahead into the fall. We'll review our health literacy consensus voting results, review some updates regarding health insurance coverage status and medical cost burden, and then go into our vote. And then we'll have a technology update, and then we'll close with community homework and next steps. Next slide, please. All right, on to announcements. Next slide. Just many of these are ongoing. You've seen us speak to the SDOH Public Health Use Case Group. So the CDC is leveraging the Gravity Consensus Model to work on a public health use case. And we really want as many of our Gravity members who attend this call to cross-attend that call. Information about that is on the Confluence. We also have many friends in kind with ONC's SDOH Information Exchange Learning Forum, which started in March and goes through July. You can enter that at any time, so we really encourage anyone to enter that. Information on each of those opportunities is available on the Confluence. There's also new invites and opportunities. There's the Civitas Network for Health Annual Conference in August, and an upcoming White House Conference on Hunger, Nutrition, and Health in September. Evelyn, anything I might have missed on those last two that you want to mention?
Oh, thank you, Sarah. We just find further details on the page, and we're excited about all these upcoming activities. So thank you.
Awesome. Okay. Next slide, please. Next slide. So this is our 2022 roadmap. You can see we are wrapping up our spring domains. We're on target to finish them as we planned prior to June. So we have some submission deadlines for some of our terminologies in June. So we always try to get things wrapped up in order to get those in on time. Looking ahead in terminology to our food access, neighborhood safety, and digital inequity domains in the fall. A reminder that digital inequity is going to be covering two different topics, both digital literacy that we brought to light during our health literacy work this spring, and digital access. So that will be all part of our work in the fall. We are finishing our ballot reconciliation for STU2, and Greg will talk more about that. And there is, although we briefly paused our pilot work, there's some hope for incoming funding for pilots. So we really hope to get that jump started as we planned. And again, this is part of why it's so important to maintain connection to Gravity through becoming a member is any updates on things like the pilot affinity group getting restarted or any updates on technology or terminology work will be communicated via email and then perhaps one-off meetings to address new things beginning. Any questions on the roadmap? All right. Okay, moving on. Next slide, please. Next slide. It's on to terminology. So, and next slide. This is where we talk about not what we are building, but what has been built and the status of it. It's my honor to pass the mic to my amazing colleague, Linda Hyde, who will talk about updates to ICD-10-CM, our new submission. So not the one that's upcoming on October 1st, our past request, but what we're putting in now. So Linda, are you ready?
I sure am. Thanks, Sarah.
All right.
We realize that, as Sarah said, this is our last public call for this spring session, and the ICD-10-CM submission deadline for the September Coordination and Maintenance meeting is June 10th. So we wanted to share with you the proposals we're currently working on, so you can just get an idea of what we're going to be submitting. For new terms, the first two new terms should be very familiar because they relate to two of the domains that we've just worked on. One is problems related to health literacy, and the other is insufficient health insurance coverage. There were also some updates to previous requests. One of them had to do with financial abuse. We did submit adult financial abuse codes as part of our work in the elder abuse domain for the March Coordination and Maintenance Committee meeting. But we realized when we were talking with other colleagues after that meeting that in this particular category, the overall general category includes both adult and child abuse. So we were kind of deviating from the structure within this category. So we did some review. We looked at literature and talked to some subject matter experts and did identify that child financial abuse is a recognized situation. And rather than leave this section kind of incomplete, we are going to go ahead and ask that they add the child financial abuse codes in those two categories for confirmed and suspected. And the other thing we realized as an oversight is that we did not ask for a personal history of intimate partner abuse for ICD-10. We did have it in SNOMED, but we forgot to include it in our original submission from the work we did for IPV. So those are the ones that are currently on the list that for being submitted. Once we have the final submission, even though we no longer have a meeting until later on in the summer, we'll share you via email the link so you can read the full submission and be posted on current status. Any questions? If not, back to you, Sarah.
Thank you, Linda. Nothing here should be surprising. The new terms are terms that we've worked together on over the course of the spring build.
So Sarah,
Hi, Lucy.
I'm sorry. Hi, everybody. Takes me a minute to figure out what I want to ask. Are these changes then effective immediately or effective in June? Could you just clarify that?
Yeah, so it's a very important question. So my preface in the beginning is this is our submission. So this is not effective until a few things happen. It has to be reviewed by an ICD-10 Coordination and Maintenance Committee meeting that might be in September, and then it has to be approved for release. So this is basically a submission that we are working on to NCHS for consideration at a committee meeting that really wouldn't be even possible for release for about a year or more.
So just a suggestion that means more work for all of you who really don't have enough to do. When you do these terminology build updates, maybe there could be an asterisk at the bottom always, which tells me the answer to the question I just asked.
Okay.
And the asterisk would say, might become effective by X. If you want more detail, call us, or something like that.
Okay, that sounds helpful. It's tricky to do that. The might be is really important there because depending on the terminology we're talking about, there are a lot of different paths to go through that are that can
Okay.
affect release.
Okay, how about not in effect until further notice?
There we go.
Then we would all know this is a work in progress, and
Yes.
you'll tell us when it's done.
I also think though, Lucy, we could clarify on the slide submissions versus releases, right? So this is submission status,
Great.
right? So it's not.
Thank you.
Yeah, so I think that might be easier. And I'm all for, I joke with the team that my penchant for pediatrics shows, I'm all for like visual signals, like stars, colors. So we will consider submission and release dates. Thank you.
Thank you.
Sarah, this is Bruce Bray. I was interested if anybody is using extensions, like if they have a SNOMED extension or something like in HL7, the VA and other places? Are they testing these out as it a local extension at all?
Oh, these new terms? No, they
Yeah.
I don't know if that's happening yet. These are literally hot off the press. So the two ICD terms we're talking about right now are just brand new from our spring build. There are ICD terms further along, both that have been released like fall of 2021 and pending release in fall of 2022. And I do know ecosystems that are testing those codes. For instance, the fall 2022 codes are almost fait accompli, even though they're not actually released yet. So I do know some systems that are testing those exchanges.
Okay, thanks.
Yeah, and that was a confusing answer, but we've been around long enough. We have ICD that was released in fall of 2021, no, fall of 2020 and fall of 2021. And then there's going to be some more in fall of 2022. And so depending on the stage of release, people are testing or actually utilizing those terms and exchanges. No, Lucy, you can't add them without the agreement of the ecosystem. So it involves a systems approval, because you would have to have all of the partners in that exchange agree to the use. You can do them internally, but it wouldn't add value, and it wouldn't be part of the interoperability aim for sure. Any other thoughts on what I just answered or the question from Bruce, which was a very thoughtful one? One thing I want to add, Bruce, though, is certainly some of our SNOMED terms regarding the same concepts are further along in the ecosystem in some instances than our ICD. So Gravity has all of the mappings for ICD and SNOMED within our master sets and our value sets. So if one was wanting to test SNOMED prior to having an ICD term released, that is definitely possible. Any other questions? All right. Okay, Kara, here we go. Next slide, please. All right, next slide. Here we are, friends. So we are closing out our spring build, and I think it's pretty remarkable how much we've accomplished and that we finished on time. We really have this system down. It really, it's a credit to how invested and engaged all of you are, and we're very grateful. So 526, it's our final vote for medical cost burden and health insurance coverage status. There is that summer break where we go kind of quiet and focus on updating our value sets, finishing our submissions, getting terminology built, and preparing for our next domains. And then in August, we will kick off another 4-month run on food access, neighborhood safety, and digital inequity. If anyone is really excited and wants to start sending us submissions on those items, feel free. We are always ready and eager. We actually do have some holdovers and from food access from our food and security build that we're ready to pull from what we call our parking lot into our active build session because some of our colleagues submitted food access elements at that time.
Sarah, are we ever going to deal with racism?
We are. That is on dealing with concepts of minority strain, discrimination, and bias, which are experiences of racism, partly, but also experiences of other kinds of discrimination, is on our timeline for kicking off in February of 2023. The reason why it was postponed is really just because of the sensitivity of the topic and really needing to make sure that we got it right. But absolutely, it's on our roadmap. We do always try to state that the outcomes of racism are also directly measured in health inequities, in population and public health data analysis. And just in keeping with that, part of what we've been testing in our STU2 are standardized methods of collecting personal characteristics information, such as race and ethnicity, gender identity, and sexual orientation. Standardization of that data through the IG will also help in our goal of understanding and addressing racism across all of our different use cases, whether that be the initial use case, of the experience of the person, which is where those measures will come in that we're going to be starting off in February, all through the third use case, which deals with population, public health, risk, and outcomes. We really need those personal characteristics information to make sure we get that one right.
Thank you.
Was that a good enough answer?
Yeah, we've been postponing this for a long time, for those of you who haven't been attending all that long, but this has been presumably on the agenda for, I'm going to say, at least a year and a half, maybe 2 years. So thank you for a due date or an ETA.
Oh,
Thanks.
Lucy, just as a correction though, and I hate, but it was actually only approved for build this past year, and it was on the roadmap for either this fall or this winter. So we haven't bumped it more. We adjusted the fall and winter, but it hasn't been bumped repeatedly or anything. I just want to make sure that that's clear. It was on the timeline this year for the first time. Any other questions?
Sarah, can you briefly define neighborhood safety just so we can start thinking about the concept?
Hi, Lolita.
Hi.
Right. So this comes from some of our analysis of existing comprehensive terms. You can see that community, that fall domain set are kind of community level domains, right? So many of the comprehensive screening tools have questions that ask about how safe people feel in their neighborhood environment. And it's not about built safety. It's not about sidewalks. It's about experiences of risk in the environment as they navigate it. So we're using those questions from those comprehensive tools to do that. It's kind of an extension in some way of the housing domain, right? So if food access is an extension of food insecurity, neighborhood safety is one of the extensions of housing. Along with that would be access to green space and other elements of the built environment that we are not addressing at this time. I can forward you some of our example questions so you can get going. I know that you're so good about that.
Yes, please. Thank you.
Awesome. Okay. Any other questions?
So this is perception by the patient sitting in front of you of neighborhood safety.
Correct.
Thank you.
This is Janice. I'm curious. So, for neighborhood safety, meaning there could be, burglaries, or it could be blight, or there could be shootings, that type of thing.
Those are some of the questions that are addressed in the measures, depending on the measure.
Okay. Thank you.
Yes. Any other questions? I love that we're talking about the fall. This feels very promising.
Hi, Sarah.
I'm just going to suggest, Sarah, that
Yeah.
this is going to be another really tough one
It is.
because the perception and the statistics, if there are any, may be completely at odds. And so the question of intervention or solving the problem will be very interesting to see how we cope with that.
Correct. The reason why we're choosing it is because it's something that's already screened for in clinical settings, right? And it does have associations in the literature. Perceptions of safety and the confusing nature of that are across almost all of the violence domains, whether it be screening for interpersonal violence across different couples and different people and different types. So the neighborhood safety element is really just an extension of that same complexity by a person in navigating their community. But I mean, it is going to be difficult, the most difficult, I think, of those 3/4 domains. But I do feel like we need to address it. So, and it's been asked for, and it's in line with with population health initiatives. It's going to be challenging though, Lucy. I 100% agree. Food
Well,
access.
the more challenging, the better for this group. Can't wait.
I
you.
know. Yeah. Any other thoughts? Shelley, I thought I heard you ask something.
Yeah,
Hi.
well, I had a question about what you're expecting in the fall? Like, what can we do for that August 18th kickoff? And in particular, the digital inequity. Like, can you talk a little bit about that?
I'd love to. Yeah. So um, I'm just gonna, I mean, I perhaps should have done a better slide on this. So for each of these, and they really are 4 domains that we bundle digital inequity, right? So for each of these, we're looking for our community to submit relevant screening questions and answers. And they include, so if it's food access, neighborhood safety, and digital inequity, again, includes 2 different topics, one digital literacy and one digital access, right? And so we want folks to submit any standardized screening questions and answers that are used in community or clinical settings, to submit any critical diagnosis statements that would be important, right? Again, we think of our 4 activities: screening, diagnoses, goal setting, and interventions. And really importantly, because this is one of those areas that we have the hardest time gleaning, is submitting any critical programs or professions that are really important for addressing the concern, right? So what do we do in the presence of this problem? What do we connect people to? What are the programs I'm referring to? Who are the experts in the field that I would be asking for assistance from? So any information regarding our 4 activities: screening, diagnoses, goal setting, and interventions across these really 4 domains: food access, neighborhood safety, digital inequity, including digital literacy and digital access. Submit them ahead of time, and we'll get ready to start building our sets and evaluate that together. And I'm going to say, in addition, if you know, any of you know in your work of experts in any of these domains, please let us know. Part of our funding gap meant that we had to pause fall domain outreach, but we're still planning on starting in the fall. I luckily have a lot of connections in these areas, so I've been reaching out to colleagues across the ecosystem, trying to make sure that we have a robust team of subject matter experts to assist us in the fall. But part of it can be connecting us to experts that you know in your own work, and we would really appreciate that. Anything else? Shelley, did that answer your question?
Yep. Thank you so much.
You're welcome. And we'll make sure to send everything that I just said, but neglected to put on the slide, in our outreach email on next week, because we always do a follow-up email. So our weekly emails will make sure to include the information that I just mentioned.
Sarah, could you preview for digital inequity? I'm already trying to think of the elements that constitute inequity: access, speed, number of computers by number of children in family, language. What else is going on with digital inequity?
So the core element of digital access is connectivity, right? So it wouldn't be most of the screeners that we utilize in clinical settings talk about connectivity and connectivity differentials in rural and urban environments, differentials in housed and unhoused individuals. Like, can I access the internet, right? We do understand that equipment is part of that, so we'll have to address that. We've addressed that partly in our material hardship domain. So whenever there's cross elements, like not having a phone is actually part of our material hardship build from before. So we won't have to duplicate things we've addressed in the past, but the access is about connectivity, right? And then digital literacy, again, was pulled out of our health literacy really as a specific subtopic, right? Because it has applications and use cases that are outside of just health, right? So we were asked to build a specific digital health literacy term, but then backed up and realized we really should just make sure we build a comprehensive digital literacy term because of its importance across the ecosystem in different implementations, not just in healthcare use cases. So it's about connectivity and literacy. And again, Lucy, if you want me to, I can send you some of those screening tools that might show you the pathway.
Thank you.
But also these align with Healthy People 2030 goals. So there are public health and population health guidance that we're using to get there.
Great, thank you. I would appreciate some links. Thanks.
So I'm sending neighborhood safety to Lolita and digital inequity to Lucy. I'm just saying that out loud. Okay. All right.
So Sarah, in the digital inequity field, it's a fairly hot topic in informatics now, particularly with artificial intelligence and machine learning, and the biases and inequities there. Is that fit here, or is that fit somewhere else?
Yeah, so Reed is kind of asking a question about that as well. Again, I am not a subject matter expert in digital inequity. I would hate to form the guardrails for that conversation prior to our work in it. Just noting precedent, like for instance, the correlate would be us starting to work on social isolation and then actually convening our subject matter experts and doing that work and realizing that we had to address social isolation, loneliness, lack of social support, and relationship quality, right? So I'm not going to, I say we will, as per usual, Gravity will build in alignment with standardized screening questions and answers that are inclusive of the domain of reference and any subdomains of importance, right? So you have our meta domain, and then we always break it up into screening questions that can take us to specific subdomains that have clinical and public health relevance. That sounds like a dismissal, but it's meant to be more expansive than that. I don't want to presuppose, I don't want to assume that we're covering or not covering anything until we actually dive in. Is that fair to say? And then anything that we do have a precedent for pulling out anything that is identified as an inequity or a barrier that is not specifically the domain at hand, but is critically important. The digital literacy domain is proof of that, right? So if there's cultural differences or accessibility differences or anything that's complicating the kind of Venn diagram of the problem, but it's not specifically in the domain or its subdomains, that's where it goes in the parking lot, and we build a separate plan for that element. Does that make sense?
Yes, and there's certainly a lot of evidence coming out now about clinical disparities related to digital health,
Yes.
tool, particularly around AI and things. So, so that obviously should be covered somewhere. And I'm just curious because the title sort of fits there, but it may
Yeah.
be separate.
You know, and it makes me think of there will be person level and organizational level responsibilities here too. We always make sure to think about that work. So Bruce, I look forward to having you become part of our work in the fall and helping us guide that. But again, if we address anything that's not specifically within the domain, it doesn't mean it's not just addressed. It just means that we build a pathway to it itself.
Right.
I want to second what Bruce just said. The New England Journal has been covering inequity in algorithms, language, procedures, almost everything you can think of for the last year. So I hope there's somebody who's going to at least leaf through that literature to see what about it can help us understand digital inequity better.
Yes, and I think the only thing I'm going to say is so it's kind of like healthcare access is a meta concept under which there's many topics we didn't address. Like we addressed material like medical cost burden, we addressed health insurance, we didn't address access to a PCP. Digital inequity was just the bucket. Is a bucket under which there's many different subtopics. We know we're addressing connectivity. We know we're addressing digital literacy. We will likely identify lots of subdomains and children that are within that as part of our work.
Right.
Just the NIH has a $100 million dollar initiative addressing just this issue, including health equity and diversity in participation in computer science. So I'm going to put the link in the chat for that, in case people want to follow up with that topic.
Thank you, Matt. And I see. So if somebody has an idea for a subject matter expert, if you could do me the favor of sending an email to gravityproject@emyadvisors.net, that would be lovely. Because we really want to make sure that we get all of those ideas. And because if in an email you can then help us connect us to the next person. So if that would be really lovely if you can do that. I see Muriel. And Muriel, hi. I remember. It's nice to see you again. And then I think so we have Lolita's comment. Yeah, so not to put Mark on the spot, but I do trust that my friend Mark will help make sure that any policy elements are addressed. I see your comment there, Lolita. And then and then yes, and then of course there's Marcus knows Abner as well. I know Abner from Twitter, which is a very funny way to say that you know somebody, but
Oh, you know, well, yeah, I know him too, but he's really, he's great in this area.
that'd be
If,
lovely. Yeah.
yeah,
Yeah.
I'll send that in, Sarah.
Thank you so much, Janice. Okay. Perfect. Okay, any other, that was really helpful. And again, if this is our last meeting, this conversation was really important. I was going to have these kinds of conversations in the community homework and next steps, but it's important now too. Any other thoughts? Again, I would never claim to put the boundaries on any of our domains until the subject matter experts weigh in. We've learned our lesson consecutively with every single one of our domains. So I was only a subject matter expert in food and security, and since then I've just been a convener and a sorter and a leader. So, all right. Okay, any other questions? And then we can move on. Okay, onward. Next slide. Here we are, we're voting. Next slide. Woohoo! Wonderfully, we reached consensus with our health literacy vote. It was really an incredible amount of work, and I'm really looking forward to those terms becoming part of the ecosystem again. Our consensus vote is the first step. The terminology team then works with each of the relevant terminology organizations, whether they be registry for those LOINC terms for screening panels, NCHS and SNOMED for diagnoses, and then SNOMED for goals and interventions. So there's a lot of work yet to do before these become part of the ecosystem and the value sets. But this was just a huge amount of work, and I'm just very grateful for everybody. Fantastic. All right. Okay, next slide, please. Next slide. I love that everyone was so busy thinking about the fall that they didn't, but that health literacy vote was really amazing. Next slide, please. I just wanted to preface the next element that we're talking about with just a reminder of some of the general interventions we have. So when you're voting on the sets, there's some core programs that go across all of our different domains. Next slide, please. Denise, thanks. And then these are some other general interventions that go along with care planning. Again, I just want to state, we talk about this in our technical work, but many of these terms for our existing domains, such as food insecurity and housing, are already in the ecosystem that were released over a year ago. We really encourage our ecosystem to give us feedback. So as we go quiet with our public calls, the work of piloting across our 3 tiers is actively happening. People are actively using our terminologies. So look forward to emails about how to engage in the pilot affinity group when we are able to kick that back up. Next slide, please. And here, this is the reason why I gave those prefaces. So across each of our different domains, we've been asked to create interventions directed at the caregiver for the benefit of the patient. We were asked specifically in health literacy. We were asked continuously across other domains. You can see some of those caregiver terms also being critically important to our friends in pediatrics in the ICD codes that are going to be released in October. They weren't asked for by us, but caregiver relevant terms and diagnoses are critically important, as we know. An example of a general intervention concept might be coordination of subject's care with the caregiver of subject, right? That's incredibly vague, but it could be a general parent term that you could put in that would be applicable across any different domain. The problem is we hit a little complexity when it comes to such terms integrating with SNOMED taxonomy, our value sets, and the IG, right? And so this is the sticky wicket. Like, so we are going to try to see what we can do. However, if such term, coordination of subject's care with caregiver of subject, was modeled in SNOMED as a situation, which is a type of term in the SNOMED taxonomy, as it could be, as some other similar terms are, it would not align with fire constraints for procedure and service requests and would not match with our value sets and our IG. So we are advocating for this term. We will work for it. We will try to figure it out, but it's kind of a bit of a rat's nest because of the complexities with SNOMED and the constraints of fire for procedure and service request in alignment with our IG. We didn't want anyone to think that we were ignoring this statement. It's been asked for so much, but we just have to figure out how to address it within the constraints of both our terminology and tech. Does that make sense? It might be too technical to understand, but we wanted to make sure that everybody had heard the response, right? We care about this. We're going to try to figure it out, and there'll be updates when we come back around. Does that sound good? Thanks, Denise. Denise is always good at letting me know I'm heard. I want to thank Teresa for being such an amazing advocate and submitter of terms. So this was driven again to importance by a submission from Teresa Gerard. So thank you so much. And we're going to try to see what we can do, and then we'll come back and give updates when we reconvene in the end of the summer. Next slide, please. All right, next slide. No updates regarding screening questions and answers. So we're heading into the vote, guys. So this is the final updates before we give ourselves the vote, the voting links for health insurance coverage status and medical cost burden. So there's no updates with the screening questions and answers or the definitions. Next slide, please. There are no updates with the screening tools, as I said. Next slide, please. There are no updates with our suggested diagnoses. So these are unchanged from the last time we met. Next slide, please.
Sarah?
Yeah?
I think the uninsured medical expenses.
Oh, yeah, sorry. Linda's correcting me because I missed my own key. Linda's so sweet. I was declining a phone call, so I was multitasking. The strike through on uninsured medical expenses was because we basically did a deep dive. We're very grateful for an end-to-end review comment. And we realized that although uninsured medical expenses is aligned with health insurance coverage status, it isn't a specific outcome necessarily of screening for health insurance coverage status, as you could be covered with insurance and still have uninsured medical expenses if you have a high deductible plan. We pulled it in because it was one of the few terms that existed in SNOMED, but at this time, in a collective review, we realized the terms that are not struck through are the most appropriate for this domain. And all this means it already existed in SNOMED CT, it's a bolded term, so we're just choosing to not include it in our value sets at this time. It's aligned, but not specific enough to be relevant for our screening questions and answers. Any thoughts on this? Thank you, Linda. Okay, next slide. There are a bunch of updates here. So everything in green is new. Lucy, I want to thank you again for your incredibly astute review. After the meeting 2 weeks ago, we reached out to lots of individuals regarding Indian Health Service to make sure that we got the naming of Indian Health Service correct. Because it is aligned with a tribal designation, and because it's part of really original treaty acts, calling it coverage was a default term that we dropped on it. We use coverage for every single other outcome of screening for health insurance, but it really isn't applicable in this sense. So we worked to try to come up with something that would be applicable, reviewing IHS literature and eligibility documentation. And at this time, we're just electing to change the term to eligible as opposed to coverage. because one, if you look in the literature for IHS, that's a more appropriate way of saying it. And this originated from Lucy Johns asking questions about whether one has a card or not. So Indian Health Service eligible is the revision from Indian Health Service coverage, which really wasn't applicable in this case. And Lucy agrees. Fantastic. We also had a recommendation for state-sponsored health insurance coverage. I think this actually came from Teresa as well. Thank you so much. This is an option within our different screening approaches. It's very appropriate because there are some instances where this would be appropriate. And so we're including this. We did work with our colleagues at FIRM, and for now, what we're doing is stating TRICARE coverage. TRICARE applies to active duty individuals and National Guard individuals, and so it's a general parent. We do have capacity in the future if there's sufficient use case to build children under TRICARE that could be the different types of TRICARE coverage. But for right now, just to make sure we have a term as part of our set, we're starting with a general TRICARE coverage term. And then we also had 2 submissions and requests for adding a Medicare drug coverage term. This is of course Medicare Part D, but we are not going to be calling it Medicare Part D except in a synonym within our build. So we're asking for a Medicare drug coverage term, and then there'll be a synonym of Medicare Part D when we build it in when we attempt to build it within SNOMED. Any questions at this time on these updates? So the change in the status of Indian Health Service, and then the addition of state-sponsored health insurance coverage, TRICARE coverage, and Medicare drug coverage.
Sarah, could you give an example of what you think is state-sponsored health insurance coverage?
There are multiple examples. We had extensive conversations regarding this. And so the problem is that there are some instances where there are simple state-sponsored plans, right? There's some instances where there are state and federal partnership plans, right? It depends on the state. It depends on the implementation. However, what we realized in those instances, some of the qualifying programs did not fit into our existing options. They didn't fit into Medicaid, Medicare, or Medicare Advantage or private. And so we had to offer another term. It's a state by state thing. I guess
I'm thinking of, suppose you get private health insurance through a state program resulting from the Health Insurance Act.
That would still be, well,
what would that be?
That would still be private health insurance. So this is an instance where it's a fully state-sponsored plan.
Yeah, this is Teresa. Yeah, some states in the past have had what they call the high-risk pools. So there are some that have continued that or laid in new ones. So they've actually segregated a portion of the population and assigned them into these pools. So that's one example.
Minnesota.
Public option also, right? Might be that. Like we have a public option in Washington State. Oh.
So Lucy, more importantly, we when we looked at all the different state by state possible applications for this term, without this term, there were some covered individuals who would fall through the cracks, right? So we just want to make sure that there's a term that covers individuals in different settings. We also, in the state in general, this is something that came up in our Indian Health Service work, we want to make sure that everyone's aware that sometimes you might have 2, right? So this isn't a one. So when you're answering these questions, most of my patients have Medicare and something else, or they have Medicaid and Medicare, or they have Medicaid and Indian Health Service, right? So we also acknowledge that individuals in real life are kind of cobbling these things together, but specifically, a simple state-sponsored health insurance coverage plan is both part of all federal surveys of health insurance coverage. So you'll see it in our screening questions and answers as a separate outcome, right? And there are instances where it still exists. So in order to not miss this population, we felt like we had to apply it.
Thank you.
All right. Whew.
Sarah, this is Carrie. I have a question.
Carrie?
Hi. Hey, is our health cost coverage that are provided by an employer but are not part of a insurance plan, um, is that under private health insurance or is that something else?
I do not think that that would qualify as insurance.
So at our association, actually, we have a high deductible insurance
Oh,
and
you
our
mean, yes, okay.
and our employer covers
The deductible.
a certain amount of cost, not just a deductible, but any other. We submit our bills to them and they cover, we are responsible for like $700 and they cover the rest.
Yeah, so I have the
So it's
same
like
thing.
stopgap.
Yeah, so I just joined an FQHC, so I have
Yeah.
the same. So the health insurance coverage is an incredible high deductible plan, right? My employer covers X portion of that deductible just for everybody, right? But the health insurance coverage is the private insurance that we all belong to. And there's other screening questions and answers that might get you to that gap, but they don't align with health insurance coverage status as a domain. I wouldn't think. Does that make sense? The specific HSA, FSA funds,
Uh,
you know what I mean? Does it make sense that the money?
yeah.
Yeah,
Okay. When you put it that way, yeah, then
yeah,
that. But yeah, I'm wondering what does cover that kind of gap because I think,
that's critical, right?
yeah,
But that's
and
why health insurance
taxes.
coverage is its own domain and is not necessarily aligned with cost, right? Because so if you're covered, costs are a whole other spend and costs and is a whole other thing. And then Lucy, unfortunately, employee, that one's already in SNOMED, so we'd have to change it. So it exists as employee group health insurance coverage. Not written in stone. We do a lot of changing in SNOMED, but we'd have to make a use case for it. Any other questions on this page? I hope I've done it justice. All right. Okay, moving on. Next slide, please. Okay, so that was the only big update within health insurance since we last met. And then I think we're going to go directly on into medical cost burden, correct? Next slide, please. And next slide. No changes to definitions for medical cost burden or screening questions and answers. Next slide. No changes here to screening tools. Next slide. This is the work we did before. So we changed it to burdensome, which made a lot of sense, and that has not changed. Next slide.
Sarah,
Yeah, hi.
hi there. Could you go back to the screening questionnaires?
Yeah,
You mentioned the MEPS
yeah,
one, and the one that was listed in the master document related to cancer.
yeah. Oh, is that one not on here?
Well, my question was going to be, I was wishing that we could substitute something like medical condition for cancer because there are very many conditions that are very costly that which those questions would apply, not just cancer. And it made me uncomfortable.
Yeah.
Scoped it down to just cancer.
So unfortunately, it's not within gravity's scope to change questions and answers that are in the ecosystem and are standardized. So if someone else has adjusted the MEPS question or the cancer questions to be general, and they're in the system and being utilized, we will happily add them to our screening tool set. But we don't personally change any screening questions and answers within the Gravity project because part of our work is to standardize, as a standards org, is to ensure that we're elevating things that are already in the ecosystem and are already disseminated. And that would be a conflict in terms. But if you can find an implementation of the similar questions that have been like audited or edited by anybody, like let's say a health system changed them or, a community change them as part of a QI initiative, we will happily add them to our screening tools.
Okay, that's great. And I totally get everything that you said. It's more of a question out to the group if there's any awareness of anything like that out there.
Thank you.
Okay.
Work to be done. Okay, next slide. Here we are, diagnosis again, next slide. There are some significant revisions in medical cost burden goals that apply to a kind of audit that we did across making sure that we standardize language across all of our domains. So one of the things that we wanted to do is really standardize the way we talk about medicines in previous domains, align it with SNOMED, and make sure that we're consistent in all of our terms. So we changed medicine to medication because that's consistent with other implementations within SNOMED CT. Small change, right? And then in response to all of the requests for medical supplies, medical equipment, etc., right? There were a lot of different requests for that. We did a deep dive into existing SNOMED CT terminology, and it's quite complex, actually, the ecosystem of the differentiation between supplies, equipment, and device. And so what we are recommending at this time is alignment with the existing SNOMED CT term, which is utilizing the statement clinical equipment and or device. And those individuals who are familiar with SNOMED will say they don't like and ors. That's true. However, this is precedent in SNOMED and we're just matching it. So this way, this term meets everything else they've already done. So we think ahead about trying to build with SNOMED because we meet with them every week and we're building in alignment with what they already have. And then that makes it easier to sort into the taxonomy. So the two changes you see here are actually not changes in content or intent. They're just changes in wording to align with existing SNOMED CT approaches. Does that make sense? Meet with SNOMED every week, yeah. We do, and they are lovely. We meet with both the National Library of Medicine folks on John Snyder and International with Kathy Richardson. So we're very lucky. And it just shows SNOMED's engagement in our work, and we're very grateful for the support. Any other questions? All right. So you'll see these reflections expressed on the master. Next slide. All right. Those are the small little bits of updates on our health insurance coverage status and our medical cost burden. Again, these were small. All of them were in the master files that were uploaded onto the Confluence prior. So they were available for public review. And now we're going to go into our vote. Next slide, please. All right. It's a little emotional. This is our final vote of the spring build. So we did health literacy last time, and we're moving on to a vote on both of these different domains. I want to review what the vote means and the voting process. So yes is a yes vote does not necessarily mean that the deliverable is the ideal one, but it's better to move forward than to block the deliverable. Yes with comment is when you say yes, but you really want to see if something's changing. I do want to note that we do have some comments to get back to two of our colleagues from our health literacy work. We've been busy getting our master files ready for health insurance coverage status and medical cost burden for the vote. So when you say yes with comment, it just means that I want to move this forward, but this is an idea for something that has to be changed or I would like to see represented. All of those comments have to be submitted to Gravity by next week. So the due date is an email to gravityproject@emiadvisors.net by 6/2/2022. The same holds true for formal objection. By now, we've been on this road together for 4 months. So the hope is in this consensus process with public engagement, any critical must-stops would have been addressed prior. So, and there's lots of thoughts and feelings and work in the product that stands right now. So if you formally object, it's important that you include a pathway for resolving the objection in a way that meets the known concerns of the rest of the group. You can still do a formal objection. We really want to make sure this is an open process, we just would want you to represent what you, your pathway to resolution in an email comment to gravityproject@emiadvisors.net, again by 6/2/2022. So yes requires no email. Yes with comment and formal objection both require emails received by 6/2/2022. And then of course, any member is able to abstain. Does the vote include comments for typos? Absolutely. So if you notice a typo, you also can just drop it in. So if there's a typo on the Marion, if you notice a typo on the master file, you can just email us directly. You don't necessarily have to submit it as a comment. We'll just promise we fix it. I have to say, Google Sheets is not so great about typos. We do all of our work on. Oh, you did. Oh, okay. So sorry. So we'll try to find that, Marion. I'm so sorry. We do all of our work within Google, so it's difficult to catch typos in Google Sheets. Any other questions on the voting?
Sarah, I have to confess, and I hope I'm not the only one. I cannot keep in my head whether I have voted or not on anything. And I'm wondering, since it goes into a system, whether accompanying all of our names on the name list of, Gravity members, could there be a signifier? You have voted on this and this and this, or you still need to, or I'm sorry.
No, that makes sense. I mean, I think that we definitely have that data. We can figure out that data. We do collect. I mean, I'm going to be that Sarah B. Are you on the call? Sarah B. is the brains behind this whole thing.
Hi, I'm on the call.
Hi. Sorry to put you on the spot, but you hear what Lucy's asking for. Do you think we can somehow help her with that?
Yeah, I'm thinking. So let's see. We could have the voting poll set so you could see responses, and that way you could just see if you voted. Would that be helpful?
Yes, I wasn't planning on whether I voted yes, no, or abstain, just something to tell me
I voted.
that I've done this. Thank you.
Yes.
Whatever it is.
We can figure that out.
Okay.
Thank you. Technology will help us. Any other questions on voting? All right. Next slide, please. All right, so there is a poll, as there always is. And the poll is a vote for both health insurance coverage status and medical cost burden. It's due by tomorrow, Friday, May 27th at 5 p.m. For anyone trying to capture the poll from WebEx, sometimes you have to click on it twice. If you want us to email it to you, just let us know. We will happily email it to you. We really try to make it accessible. Just let us know if you're having any problems. gravityproject@emiadvisors.net. You're voting on those two master files again. You have to press submit for answers to be recorded. If you're voting yes with comment or formal objection, you have to email those comments to us by 6/2/2022. Can we drop? Yay, Marianne, can we drop what in the chat? The vote link is at 5:02 p.m. in the chat, if that's your meaning. I think it was at the same time you commented. Is everyone all set?
Also, Lucy, at the bottom of the form, you can click a button that says, send me a copy of my response. Maybe that would be helpful.
Thank you, Suzanne.
I wish. Thank you. I'll do that.
Okay. Wonderful. All right. Everyone else set with, and then we'll move on to our next topics. All right, next slide, please. All right, I'm gonna have another moment at the end, but I want everyone to take a little moment and just reflect on what we've done over the last 4 months, right? It's a regular old Thursday afternoon, but we just completed some pretty amazing work across 3 really critical domains, and I'm very proud, right? You should all be very proud. You all worked very hard. And thanks for sending in those votes. We look forward to giving you an update on the status of the vote next week. All right, and I think I'm passing the mic to my friend Greg to give a tech update. Next slide. Is my friend Greg here?
If he's not Sarah, I can do it, I think.
Thank you, Monique. Monique is an amazing contributor, and she works across both of our different streams. So Monique Van Berken from the American Medical Association, thank you for pitching in. Next slide.
So I think the issue here is that the ballot process for the IG is that feedback is received with ballot tickets. We had about 100 of those total. And Bob Dieterle basically works through those with the groups on the Wednesday afternoon IG call. He proposes resolutions for those. The things that get resolved on those calls get put into a block vote that's then presented to the Fire Primary Care Working Group. And if they approve the approach we suggest to resolve the ballot item, then we can start working on those. And so we've basically worked through almost all of the 100. There's a few more that will be required to be submitted. The first 100 or so, or 98, have been approved by the Primary Care Working Group. We have yet to apply some of those actual changes in the implementation guide, because we don't do that until they're approved. And then we have to wait to build the guide and resolve QA issues. But the remaining work, is hopefully going to be completed in June. So the IG work is moving forward smoothly. And that's probably it there, Sarah. Unless there's another slide that he had in there.
I think it's just about the Connect-a-thon. Do you want me to handle that?
Oh, yeah, right.
Or you can go.
So, yeah, there is a mid-July Connect-a-thon. Aaron Sieve is working on, getting participants for that. So the registration is until May 31st, and I think beyond. And that will be, further information will be posted on the Gravity Track site through Confluence. But this is still in the works as far as I understand it from Greg and Aaron. That's it on that one, Sarah. I think there is nothing further.
There is nothing further. Yeah, I'm trying to reply to, Donald, I wrote this in the chat. Don sent a very wonderful email with policy alignment. And Don, I'm going to send the policy you're speaking of to our colleague, Mark, to make sure that we're always integrating Mark's expertise in policy. But the email that was sent this morning needs to be submitted as a formal vote for it to count, I hate to say.
Yes. So I was unclear if the email counted as my vote, or if I need to go ahead and do my vote on this.
If you can so kindly submit a formal vote via the poll, that'd be lovely. But I have already read the HSS recommendations, and I'm super excited about talking to you more about them. All right, Donald, was that a good answer?
Terrific, thank you.
Okay. All right. All right, so please do register for the Connect-a-thon. We really want to make sure that we have folks there. Again, I'm going to say something really important about the Connect-a-thon. So if there's ever, we hear consistently that sometimes cost is a barrier to the HL7 Connect-a-thons. The CMS Connect-a-thon is free to attend. So it is a perfect place to come and participate in the important testing of our ID. And we really hope we have as many members there as we possibly can, and different stakeholder types. And if you need help finding friends and partners to come to test with, just let us know. We will try to match you with people if you really want to come and test things and test exchanges, but you don't know if you can find a different partner to test with. We're there to try to see if we can connect you with people. All right, next slide, please. Community homework and next steps. Next slide. All right. It's a little emotional. So general, as always, catch up on materials and recordings on Gravity Project Materials Confluence page. Please, please, please submit your votes for medical cost burden and health insurance coverage status by tomorrow, 5 p.m. Eastern Standard Time. And then I just wanted to add a little thing, like we've accomplished great things this spring. We really look forward to seeing you again at summer's end. And we just want to make sure that everyone knows in the meantime, we're working hard to ready ourselves for our next efforts and we'll miss you. You guys are my Thursday grounder and I will miss hearing your voices and I cannot wait to see you again on August 18th. Any other thoughts before we close? Congratulations, everybody, for a spring build. We are so grateful for you all. And when I say I miss you, I will miss you. So,
Thank you, Sarah.
yes. Okay. Thank you so much, friends. And then Marianne, I'm going to go look for that email to make sure that you're, you don't have to say the same thing twice. So that your typo question, I will go look for it. Thanks so much, friends. And do try to find the announcements and then look forward to email updates and have a lovely summer. And we'll see you on August 18th.
Take care, Sarah.
Bye, friends.
Bye-bye.
Thank you. Bye.
Bye, everybody.
Bye-bye.
Great job.
Bye. Thank you.
Take care.